All right, hello, good morning. I would like to say that I'd like to follow Afton after she gives talks because my pre-talk anxiety went from like an 8 to a 4 because her slides were so pretty and calming, and I think the message is so important. So thank you. All right, I have no disclosures. So first, I just want to give an overview of this talk today. I think it's amazing that there are so many people here who are interested in learning more about chronic pain. I'm sure you all heard yesterday about the number of people who are impacted by chronic pain, and I imagine most people in this room are in some way touched by someone who's living with chronic pain. And so our collective goal here today, in terms of what my colleagues are doing, and I imagine many practitioners in the audience are doing, is to really improve the lives of people who are living with chronic pain through innovative research and novel treatment. And so I wasn't here yesterday, so I don't know how much they talked about the opioid epidemic, but everyone kind of knows what happened in the 90s. A new opioid came onto market and was touted as being safe and effective, and so prescribing rates really skyrocketed. But now with some knowledge, 20 years later, we recognize that the consensus is that really long-term opioids are not a particularly effective option for chronic pain, and they carry numerous risks. The problem is, however, that there are millions of chronic pain patients who were started on opioids for pain management because they were thought to help, who are still continue to use opioids. And so the important question, I think, that isn't getting as much attention and doesn't make the headlines as much is how do we reduce opioids among chronic pain patients? And so what I'm going to be talking about today is 2 studies that we hope will help us develop a roadmap for designing an individualized opioid cessation intervention for our pain patients. Next slide. Move along. All right. So I know there was some presentation yesterday about the CDC guidelines for managing chronic pain in the context, or managing opioids in the context of pain. And so I'm just going to touch on a few points. What the CDC guidelines recommend when it comes to tapering is that opioids should be tapered or discontinued if the benefits of opioids don't outweigh the risks, if there's lack of sufficient evidence of clinically meaningful improvement in pain and function, which we typically define as a 30% improvement. Sorry, hold on one second. There we go. And also if people are showing signs of a substance use disorder or co-use of benzodiazepine. So during my talk today, I'm really going to focus on those top 2 points. So first, what are benefits? So Dan and Afton talked a little bit about this, but the question is, are there any benefits to taking opioids? Should we put any chronic pain patients on opioids? And I think when we're talking about benefits, we're typically talking about kind of the images below, is that we want people to get back to, as Afton talked about, getting back to living their lives. We might not be able to completely eliminate pain, but we do want people to find strategies so they can live a meaningful and productive life. And let's see, where's the cursor? It's so different from the Mac. All right, and so what do we know about benefits? So we have 20 years of research. The consensus is generally that about 80% of people are not getting long-term improvements in pain or functioning. And so really the conclusion is that there's insufficient evidence to support the long-term use of opioids for chronic pain. So what about the risks? When I think of risks, and when you all think of risk, I assume we all think about things like addiction, overdose, dying, and I think that we can think of risks at an individual level, but also at a societal level. So let's first talk about whether or not chronic pain patients are at risk for addiction. I know this was covered yesterday, so I'm really just going to touch this briefly. All right, so misuse and addiction-related behaviors in chronic pain patients range from, I don't think you can see that number, 15 to about 26%. Carefully diagnosed substance use disorders is less than 8%, and I would say that's relevant to what I see clinically. Most of my chronic pain patients, I don't think have a true substance use disorder. I think there are people who have problematic opioid use behavior. I think most patients are very dependent on opioids, but in terms of true substance use disorder, I don't see that clinically, and I think this research suggests that as well. What about overdose and death? So Are they at risk? Yes, the answer is yes. So risk increases at higher doses and when patients are using other medications like benzodiazepine. In fact, I think, Chad, you can correct me if I'm wrong, but I think I've seen some data that shows about 75% of overdoses, there's another substance in the system. So opioids are usually combined with benzos or alcohol. So I think that's really important to keep in mind, the importance of, it's not just about opioids, it's also about using other medications while you're taking opioids. All right, so I'm going to focus on this point right now, this concept of opioids should be tapered or discontinued if the benefits of opioids don't outweigh the risk. So if we consider the data that I just talked about, that talked about benefits and risks, most people would fall into the category of probably needing to be tapered off of opioids. It seems to be like that a lot of chronic pain patients would benefit from opioid cessation, and there are a lot of challenges associated with tapering patients off, which is what motivated the research that I'm going to be presenting today. Okay, so we've been studying opioids at the Back and Pain Center for about the last 5 years. I think Chad talked a little bit about the work we do at the Back and Pain Center yesterday. But I want to share some data. But before I do that, I want to give you kind of a picture of this setting. So it's an outpatient tertiary pain clinic. We see approximately 1,000 new patients every year, and we see people with a wide range of chronic pain conditions. So we see a lot of low back pain. We see folks who have back pain, but also centralized pain, migraines, complex regional pain syndrome. So we kind of see the whole gamut of pain patients. And the common treatments that patients are getting when they're being seen for treatment are certain procedures, so injections like steroid injections. We're seeing a lot more spinal cord stimulators being used as we learn more about how to use those in pain management, medication management, and that includes things like opioids, transitioning people to bup and Suboxone, and some of the SSRIs and SNRIs that are thought to help with both pain and mood. And then also pain psychology. So we have 2 pain psychologists, myself included, and a social worker there. And so we really try to take a multidisciplinary approach to managing chronic pain. As you heard today, managing pain is really complicated, and there is not one thing that is going to work. Usually, to really be effective, you need to treat all the different dimensions of pain. That includes physical, emotional, et cetera. And so I just wanted to also give some data on how many patients at our clinic are current opioid users. So Afton mentions the new patient packets that we collect on all of our patients. So we looked at the data over the last 5 years, and on average, about 40% of new patients are reporting current opioid use. So that seems high, given what we've just talked about the fact that, generally speaking, we don't think that there's enough evidence that these opioids are effective to be maintaining these patients on chronic opioids. So then the question is really, what do we do at a clinic if you're a provider and you see this new patient and they're an opioid user? How are you going to make decisions about what to do with that patient in terms of their opioids? So I'm going to talk about 2 studies. The goals of the first study were to use data from current opioid users to explore the potential barriers to opioid cessation. And so I think it's important because if you're a provider, most patients, if you talk to them about opioid cessation, are probably not going to be super enthusiastic. They're not going to be really excited about their provider telling them they want to take them off of medication. Many of these folks have been on opioids for decades. And so thinking about these different barriers, the key points I'm going to talk about is, I think it's hard as a provider, thinking about how does a provider determine if a patient should actually initiate opioids? Second, do chronic pain patients see opioids as risky? And then finally, are the patients at our clinic motivated or thinking about change? We kind of think about change as the stages of change. And what you want to see is that people are motivated. The group out in Seattle at UW developed, University of Washington, Sullivan, they developed a really great opioid cessation intervention, and it failed because they couldn't get people to participate in the study because people weren't motivated. People want to keep their opioids. All right. Sometimes it works. Okay, there we go. So really quick, the study included 191 current opioid users. We recruited them from the Back and Pain Center. They completed 2 online surveys. There was a baseline survey where they completed data on a clinical phenotype. We've talked a lot about what we collect in our Apollo packet, so pain, functioning, mood, et cetera. Also, we were interested in understanding what their perceptions of the helpfulness of opioids were, and also looking at these potential barriers to opioid cessation. And we also followed these folks longitudinally. reassessing their clinical phenotype, looking if between the time when we saw them first till the follow-up, which is around 3 months, if they had a cue to action, meaning had a provider talk to them about changing their opioid use. And then we actually did assess changes in opioid use. Unfortunately, I'm not going to be able to talk about those data today, but I think they're going to be very interesting. All right. Okay. All right, so one of the ways that we evaluate whether patients are benefiting is looking at people's clinical scores. And so, so things like the brief pain inventory and the PROMIS physical functioning are really common tools that we look at both to determine if a medication is useful or if an intervention has been successful. So I just want to draw your attention to the one of the interesting findings in this data. So looking at the portions highlighted in blue, if we think about what a 30% improvement in pain is, technically anyone on a 0 to 10 scale, if their pain score is above a 7, they cannot have that's not a 30% improvement in pain, nor is it a score of 14 or above suggestive of 30% improvement in functioning. And so I think this is important because if you think of what the CDC guidelines are telling us to do about tapering is if there's a lack of clinically meaningful improvement, they should be tapered, but I'm not sure how providers can use these scale data to really, really, truly determine that. And so my main point is just establishing benefit is going to be really complicated. And so if you have a new patient who walks into your office, you're seeing them for the first time, you have somebody who says, I'm a 9 on pain. Presumably that would make you think, oh, this person's probably not benefiting, or they're not functioning at all. Presumably that would make your kind of a red flag think, oh, I might need to taper this patient off of opioids. However, we wanted to hear from patients what their perceptions of the helpfulness of opioids were on important domains like pain, activities, sleep, mood, et cetera. And so let's look at what the patients told us about the benefits they perceive from the opioids. So this scale is a -3 to 3 scale. So -3 means that their pain is much worse, for example, or +3 would be much improved. And so this is a pretty telling slide. Virtually everyone is saying that their pain is improved. Virtually everyone is saying that their ability to do day-to-day activities have improved, sleep is improved, mood is improved. So in light of this data, how does a provider determine clinically meaningful benefit? So I showed you the previous slide where 40% of patients appear to not be getting 30% improvement in their functioning. But 93% of patients report that their opioids help with their functioning. And so I think this is really challenging. How do we make sense of this question of identifying patients who to taper when you have a clinical score that might be high, but this person is telling you that they're helping? In terms of patient-provider relationship, this is a really, I think, important piece of the puzzle in terms of how do you have that conversation with someone who clinically doesn't seem to be deriving a meaningful benefit, but does feel that their opioids are helpful. The next thing I'm going to talk about related to my study goals is, do chronic pain patients see opioids as risky? The reason we want to talk about risk is because perceptions of risk are a modifiable risk factor that tend to have a really strong influence on our behavior. If I'm doing something and I don't see it risky, I'm not going to change my behavior. We also are really good at lying to ourselves, like even when we're doing something risky, like people who smoke, we're really good at reducing our dissonance and kind of coming up with justifications like, oh, yeah, I know it's dangerous, but my grandma lived to be 98. So we also can lie to ourselves about risky behavior all the time. Okay. Okay, so do patients see opioids as risky? When we ask folks if they feel like they're informed about the risks, 72% say they are extremely well informed about the risks of taking opioids. And so that's important because sometimes people aren't informed of the risks, and one of your goals of an intervention would be to increase people's knowledge about the risk, but our folks are telling us that they're very well informed. And they're very well informed, and the majority don't believe that using opioids long-term for chronic pain is risky. 37% said they're not at all worried about taking taking opioids for chronic pain. And I think this one is really interesting. Most people think that if I'm taking my opioids as prescribed, the risk is low. I think one of the things we can't say with this is maybe they're right. Maybe for some of these folks, they aren't at risk for addiction, they aren't at risk for death, they aren't at risk for overdose. And so they just don't perceive opioids as being particularly risky. we also wanted to know if providers were talking to patients about the risk of opioids. And the answer is yes. 87% of providers are talking about the risks of long-term opioids. I think this data is really interesting. It could imply that providers maybe aren't effectively communicating the risk to their patients, or that patients didn't see the risk that the providers talked to them about as applicable to them. I think in order to think of intervention development, we need to sort the meaning of this figure a little bit better. So that's the risk piece. My final point is, are patients motivated to stop taking opioids? What would you all guess the answer is? Big no. Yeah. 64% say no. So I think the first place when you think about motivation in opioids is to think about whether or not a provider has recommended reducing or stopping opioids. And so here, the other thing that's interesting of this is 64% have said their providers have not even talked with them or told them or suggested that they stop or reduce opiates. Maybe it's because Chad and I have talked about this. It's possible that the providers are talking to their patients about tapering, and patients, again, just are not hearing it, don't want to hear it for whatever reason, and it's kind of going in one ear and out the other. Another possibility is providers aren't making this recommendation. I could see a situation where a provider had one of those patients who was telling them how helpful their opioids are, and they are not looking well on pain and functioning, and how do you initiate that conversation? And I also think it's harder to have this conversation with patients who you have established relationships with. If you've been seeing a patient for 2 years and they've been taking opioids and you've been maintaining them on them, that's a little bit of a different conversation than a new patient who's new to you, and I think the conversation is going to look different between the provider and the patient. Okay, so here's the motivation question. So yes, we asked people directly about their motivation to stop taking opioids. 62% say no. Sometimes I'm like a glasses half empty kind of person, but here I'm trying to be the glasses half full, because this means almost 40% of people are reporting some level of motivation to stop. And I think that the reasons why are really important. So 16% are thinking about stopping because of the risk. Some are thinking about stopping because they don't feel like opiates are particularly effective. 7% are thinking about stopping because their physician recommended it, and 7% are currently trying to stop. So we also were interested in looking at some group differences between the 62% of people who are thinking about stopping versus the 38% of people who are not thinking about stopping, to see if we could look at any factors that were associated with motivation. And so interestingly, there were no differences between the groups on clinical pain severity, functioning, or mood, or perceptions of helpfulness, like pain, specifically with pain and functioning. However, patients not thinking about stopping opioids were lower in perceived risks and higher in perceived safety of opioids, and they also were less confident in their ability to manage pain without opioids, which I think is what this conference really is about. So I think that there's really important clinical implications for targeting factors that might be helpful in increasing things like motivation to consider stopping, in particular, issues related to perceptions of risk, and also giving people alternative strategies for managing pain to increase their confidence. Imagine if you were somebody and you were taking a medication and it was going to be taken away and you weren't given an alternative, you wouldn't want to change that behavior. So what you really is needed is, in addition to opioid cessation, is strategies like we're all talking about here to provide alternative pain management interventions. So another thing we looked at were some other factors that we thought might decrease motivation for cessation. So the idea here was that we had people who are current opioid users sort of imagine what would happen if their provider were to talk with them about opioid cessation. Have them imagine, if I stopped opioids, my pain would get worse, it would be hard to do day-to-day activities, my mood would suffer, I wouldn't be able to cope, etc. And here's the results. And this idea of our beliefs about future consequences also have a strong influence on our behavior. If we think, if I do this, bad things will happen, we are also not likely to do that. And so here are the graphs. So the graphs on the top are pretty striking to me. So the one on the left is about pain, and the one on the right is about day-to-day activities. Universally, patients are telling us that if I stopped opioids, they believe, 63% believe a 10. They're certain their pain would get worse if they stopped opioids. 60% are certain stopping opioids would negatively impact their ability to do day-to-day activities. This is really important. This is a really important thing to know if you're a provider. Your patients are afraid. They're afraid that their pain will get worse, and they're afraid that their ability to do day-to-day activities work. Regardless of whether we think this is an accurate belief or not, it is their belief. If you look at the bottom, day-to-day stressors and mood kind of is spread out. So those don't seem to be influencing people's beliefs about stopping opioids as much as pain and functioning. I was a little surprised. I thought the mood data would look a little bit different. Just because we do know that patients, consciously or not, do sometimes use opioids to self-medicate for depression and anxiety. So to sum up what I think the first study tells us about the key barriers to cessation, I think the first is this idea of a mismatch between helpfulness and this idea of clinically demonstrated benefit. I think that relates to cessation interventions that might be really useful from a provider perspective, to give providers some tools to have conversations, meaningful conversations with their patients, to help them kind of clarify why their perceptions of helpfulness differ from what we're seeing clinically. Another key barrier is low concern about the risks of long-term use for chronic pain. I struggle with this one sometimes because I think with the opioid epidemic, we really have seen the risks from a societal level. But clinically, I don't worry that much about my patients dying, having an overdose, being addicted. I worry much more about whether or not they're getting clinically meaningful benefit. That being said, there are risks, and there's something missing in the conversation that we're having with chronic pain patients where they seem to be coming away with the message that taking opioids for chronic pain as prescribed is not particularly risky. And then another barrier is the belief that stopping opioids will lead to more pain and worse functioning. And then finally, this issue of patients not experiencing a cue to action. So 60% again of patients have not been told, according to them at least. We don't know how real that is, but that's a lot of patients who are not being told to even having conversations about tapering. It seems unlikely to me that with these 40% of patients using opioids, that 40% of these patients are deriving clinically meaningful benefit. So I think opioid cessation is quite complicated for chronic pain patients. It's a lot easier said than done. So next I'm going to shift gears a little bit. I'm going to talk about our study number 2 with former opioid users. If you want to know something, it's really helpful to ask people who have been through the experience. We know that we're really bad. Actually, if we think about the folks who are predicting that their pain is going to be awful and their functioning, we're terrible at predicting the future. It's best to ask somebody who's gone through the experience what was the reality. So study number 2 is a mixed method study. We recruited 49 patients who were former opioid users, meaning that they were not currently using opioids and had at least used opioids for 3 months or longer at some point in time, daily. And this, I don't know how much people know about mixed method studies, but really quickly they combine quantitative data. So for that part, we did an online survey where patients completed our standard battery of questions, current pain, severity, functioning, mood. We were also really interested in this idea that Dan really inspired in me, is this idea of perceptions of improvement or lack of across clinical domains since patients stopped opioids. For the qualitative data, we ran some focus groups. What I like about qualitative data is that it is a way you can really see and feel what opioid cessation was like from the perspective of these patients. I can still hear the stories going through my head from these different focus groups that we have. Joe was in the focus groups, and I know that we kind of talked a lot about just like hearing people's stories and how impactful that was for us and for them. I think it really brings to life the stories that people tell and their experience in a way that quantitative data really can't. So when you're doing focus groups or qualitative interviewing, you kind of start big and then kind of funnel down. So our themes that we were looking at is we asked people to just tell us the story of why they stopped taking opioids. And we asked them to talk about some of the barriers that they were anticipating before stopping. We wanted to know what would have been helpful during cessation, and what advice they would have to providers. So I'm going to share some of the common themes that emerge. So when you're analyzing qualitative data, what you're really doing is looking for themes that pop up. And so we found 2 themes for reasons for wanting to stop. One was that opioids stopped working, and 2, the second theme was concerns about addiction. The themes that emerged for barriers to stopping were pain will not be well managed. We heard that from our current opioids. They're also worried about this happening. Using opioids to cope with other areas of life. So this goes along the lines of we think that patients are in fact using opioids for managing depression, managing anxiety, for sleep. And lack of other pain management strategies was something that came up again and again when we were talking with these folks. When it came to asking them, when you were going through the cessation process, what would have been helpful to you? What would you have liked? One, support from the provider, and again, alternative pain management. And then finally, what advice did they have to providers? One was to explain the risks of long-term use, which I think is really interesting in context of what we just talked about in terms of our current opioid user data, and their sort of lack of understanding or feeling like their opioids are risky. And then something that came up, and again, Joe, I think you remember this, is this idea of show empathy. We ran 4 focus groups. In every focus group, somebody talked about being treated like an addict. And I think it's so important for providers. You might not mean to come off that way, but this is the message patients are getting. And it was just, I found that to be one of the most moving and striking parts of these focus groups. Just how they talked in their voice and the embarrassment of feeling shame from this. And then I think that also can create some challenges with the patient-provider relationship. And so what's great about qualitative data is you get to use some quotes. So some of the good ones that represent the themes well, I think, are reasons for stopping. Someone said, in our first group, I stopped because opioids seemed to control me. Someone who was worried about quitting, they said they were really scared because I was also taking them to keep from thinking about the other problems I had. Again, kind of reminding us that opioids are not necessarily just being used for pain. People are also, again, consciously or not, using them because what do opioids do? They kind of numb our experience. So this person was aware of the fact that they had been taking them because they were trying to manage other stressful parts of their life. Also, when we were talking about desire for other pain managements, as a therapist, I love it. If you stop, you need counseling. And then finally, this mouse cursor thing. Yeah, okay. Oh, I wish I'd known that like 27 slides ago. My life would have been so different. All right.
It's a really big bar.
I'm like trying to use these ridiculous little, anyways. All right. And then stigma. So this quote from this gentleman from our last focus group, he said, once the push started coming, the doctor I'd been seeing for years, I felt treated me differently. I felt like they branded me in with the drug seekers. And that, again, I just can't stress that enough. Just for me, this part is really important. And then just really quickly, I want to talk about the survey data. So we asked this question of these patients of since stopping opioids, my pain now is, my mood now is, my ability to do activities is. And again, sort of what we see here, what's highlighted in blue is that, let's just look at pain now over in the top corner. Most patients are saying that their pain stayed the same or improved. 46% of patients said their pain got worse. And therefore, when you think about when patients who are current opioid users are worried about their pain getting worse, there might be some validity to those concerns. Similar ability to do day-to-day activities, most people feel like they're the same or better. I mean, I think generally this is really positive. Mood, interestingly, most people felt like their mood stayed the same or improved. Sleep is a really interesting one. More people said that their sleep got worse. So 53% of people said their sleep got worse after stopping opioids. And this is something we're having a lot more conversations about at the work we're doing at the clinic, is how are opioids being used for sleep? Because they can be sedating. So, and it might be because they're using them for sleep because they hurt, but it also might be they're using them for sleep because they make them sleepy, and it's kind of a sedating experience. So I think that this story from these former opioid users provides us a picture that I think was a little unexpected. We found some things I wasn't expecting. And when we think about intervention development, another important piece is relapse prevention. And so we asked patients, how likely are you to resume taking opiates in a year? And the only predictor was current pain severity. It was the only variable that was associated with intention to resume opiates in the last year. And so I think this tells us that insufficient pain management is something that's going to put patients who've achieved opioid cessation at risk for, I guess, what I would call, in like smoking cessation, you'd call it relapse, that they would more likely seek out opioids again in the future. And so this is also something when we're thinking about intervention development that's really important to keep in mind. All right, and then, so I kind of want to just talk generally, like I think we now have sort of a roadmap for opioid cessation from some of this data. I think these studies offer us little clues. And I don't think it's going to be black or white, but the first is identifying patients not deriving clinically meaningful benefit from opioids is going to be challenging, but it's the most important first step. If you don't know who you want to taper, how do you taper them? Second, providers need tools and strategies for talking to patients about cessation. We need to address these individual barriers like motivation and risks in order to target messaging to patients to specifically increase motivation and increase perceptions of risk. And then finally, we need to provide non-opioid alternatives to chronic pain management. And so just my last, sorry, I just want to make sure I point out that we've talked about a lot of these here. Non-opioid pharmacotherapy, we have all these evidence-based interventions that Afton and Dave talked about today. Kevin, I know, talked about medical cannabis yesterday. So we're just kind of thinking outside the box of what else can we offer these patients instead of opioids. And so just finally, I think about this a lot. I'm really interested in understanding this kind of swing. We sort of, in the 90s, we swung towards pain control. Now we're back to swinging towards drug control. There's obviously no question that pain patients have been overprescribed opioids. And now we're correcting course. And I think the course correction is obviously very important. But I think still understanding what to do about patients who are currently using opioids is a question that we're still trying to understand and get our brain around. And so some questions I just want to leave you with is, what is the place, if any, for opioids in chronic pain management? And then how do we support opioid cessation while we also minimize the unintended negative consequences for our chronic pain patients? There were unintended consequences of what happened in the 90s with overprescribing, and we want to make sure we're anticipating and thinking about the potential unintended consequences for these chronic pain patients, who the majority of them are not abusing their opioids. They were just following the instructions of a provider for years. And that is all.